How to read a CTPA or CT pulmonary angiogram. First we will go down to the pulmonary trunk. At this level we can see our pulmonary trunk over here and aorta near it. So we need to adjust our window so that we can easily differentiate between a contrast and calcification in bones. For that we will just reduce the contrast a bit. And now it is easy to make up pulmonary trunk. So we will go down to the pulmonary trunk, and now we will follow the right upper lobe artery. So we do not see any emboli in the right lower lobe artery. Then we will follow the right upper lobe artery, and we do not see anything in the right upper lobe artery as well. Then we will come back and we will see the left lower lobe artery. Left lower lobe has no emboli, and then we will go back to the pulmonary trunk and see left upper lobe artery, and again there is no pulmonary emboli. So there is no filling defect, which means there is. Now we will come back to the level of aorta and pulmonary trunk, and next thing we need to measure the diameter of aorta as well as diameter of pulmonary trunk. In this case, pulmonary trunk measures 25 mm and aorta measures 3 mm, so there is no pulmonary trunk dilatation. We call it dilatation when pulmonary trunk diameter goes more than the aortic diameter. And then we will go down to the heart and we see the interventricular septum. There is no right heart pressure, there is no bowing of IV septum towards the left ventricle. So this is a normal appearance. It means there is no right heart strain due to pulmonary embolism. We will go further down to the liver and IVC, and we do not see any contrast here. It again means there is no regurgitation through tricuspid valve, means there is no right heart strain. So to repeat it again, to see right heart strain, we have to see three things: diameter of pulmonary trunk, IV septum bowing, and regurgitation of contrast in IVC. So in this case there is no right heart strain. So we have ruled out PE, we have ruled out any right heart strain. So basically this is CTPA, but we need to cover rest of the lungs. So we will change our scan to the lung window and we will see right lung first. There is lot of background emphysematous change in right lung, and we will go down to the base and then we will come up again and we will see left lung in the same way. There is again lot of background changes but no focal consolidation in both the sides. If we go to the base, there is some basal dependent changes on either side. Now we have seen lungs. Next thing is just change it to the soft tissue window again, and we have to see the lower neck. There is no, the thyroid looks fine, there is no lymphadenopathy. Going down to mediastinum, I do not see any size specific lymphadenopathy. There is one lymph node over here, but if you measure the short axis, it is just about 8 mm. So this is again not size specific lymphadenopathy. Okay, going down, there is no pericardial effusion. Okay, so, and the final thing we have to see is upper abdominal viscera. So there is liver looks fine, spleen looks fine, and there is no collection or air in the upper abdominal viscera. And the last thing is going to bone window and checking the bone lesions. I do not see any bone defect. Okay, so this is basically a complete CTPA scan, how we report. So in this case, my report is going to say this is pulmonary angiographic phase scan showing adequate enhancement of pulmonary arterial tree with no evidence of acute pulmonary thromboembolism. Stop. There is diffuse background emphysematous change but no focal area of consolidation or collapse, no supraclavicular, mediastinal or axillary lymphadenopathy, normal appearance of major thoracic vessels, and upper abdominal viscera appears normal. Stop. So this is how you report the CTPA.